Hello everyone, this is Judy from COXO. Today we will invite Dr. Marc to share the course. The topic is the obturation game from the concept to the clinical reality. Hello Dr. Marc, how are you? You should open the voice. So before the course, I will introduce how to get our certificate. The first step is follow and like our COXO page. Then leave your comment or question below the live video. At the end of the live, we will share the phone link to the comment below the live video. Please open the link and fill the form and submit to apply for the certificate. About 3 steps all done. In 5 days, you will receive the PDF format certificate in your email. Please note that the form application can be filled only one time and will be available only for 5 hours after the lecture. 5 hours later, the application channel will be closed, and after that time, we will not accept any application. Please fill on the form as soon as possible after the webinar. The form cannot be modified, so please make sure the information you left are correct. And this one is the sample of our certificate. So, Dr. Ma, please share your screen and start your presentation. Please open your voice first. Now it's unmute.
Hello, Judy.
Yeah,
Sorry.
hello.
Yeah.
Hello,
Good.
Dr.
How are
Ma.
you? How are you? Good.
Bye.
Can you see my screen?
Now, please try to share it again.
Can you see it?
No. Okay, I can see it
Okay.
now. Yes.
Yeah. Yes.
Yes.
Okay.
Okay. So please start your presentation.
So thank you, Judy, and thank you, COXO, to inviting me for this presentation about a topic that I like very much to talk about. It's the obturation. So the title of my topic today is the obturation game. And I choose in purpose the word game because for me, endodontics and dentistry in general should be a game, should be a passion. So I like to share with you my passion in this particular topic. When we talk about obturation, usually we look at something that every endodontist looked at is white lines. And we look at the white lines inside the root canal system. But, obturation is more than that. The objective of the obturation and the objective in general of the root canal treatment is to preserve the tooth. So we have to preserve the tooth by any means that we have. This is why I will start my presentation with some cases where, two cases where we didn't need to do a complete root canal treatment and a complete obturation, but we did a partial obturation, and I will explain this. So my topic will be divided in 5 parts. The first one is the coronal seal for pulp preservation. As I told you, our objective is preservation, and this preservation can be the pulp preservation. The second one is pulpotomy obturation. The third one, condensation techniques. and finally, the single content bioceramic techniques, and in some cases, the MTA plug techniques. In some cases where we can't use all these methods to do our obturation. So let's start with the coronal seal for pulp preservation. What do I mean by this? Look at this particular X-ray. On this X-ray, we see 2 molars. The patient comes with a light pain on this upper left side. 2 molars with 2 decays. One on the mesial on upper 7, and the second one on the distal part on upper 6. So what is our decision making? In this particular case, our decision making was different for number 7 and different for number 6. Number 6 had a large decay, but the tooth was vital, no symptoms, and also no exposure of the pulp. So we decided to do an obturation, but this obturation was only a coronal obturation. On the other hand, the upper 7, we had a decay that was exposing the pulp. So in this case, we opted for the white lines. White lines mean that we did root canal treatment, we did our cleaning, our shaping, and finally, we filled all 4 canals. So we have 2 different strategies depending on the diagnosis of the tooth. If we do root canal treatment on number 6, we can consider it as overtreatment, because even as endodontist, our objective is to work with the pulp, is to preserve the pulp. This is another case where we can talk about the decision making. You can see here, for example, on this upper molar, we have a large restoration that is far from the pulp, from the pulp core. And we take an X-ray, we see that we have a large radiolucency on the mesial root and a small radiolucency on the distal root. So even though there is no decay under the restoration, even though the restoration is closed, we have a pulp necrosis and we have an apical periodontitis. So our decision-making in this case is to do root canal treatment, of course. And this is what we did. Actually, I did this treatment just today, just before my lecture, to show you that these treatments that I'm going to show you is something we do on a daily basis. And you can see it was possible for me to fill all 4 canals and also to fill a lateral canal in the middle part of the palatal root. The second point is the pulpotomy obturation. So in some cases, we cannot preserve the pulp because we have a pulp exposure. And sometimes it's a small exposure, then we can do a pulp capping. But in other cases, we have a large exposure. And this was the case for this kid, 7 or 8 years old, I think, very large decay, no symptoms, class 1 obturation. This is the ideal situation for apexogenesis, and this is the ideal situation to work to do a partial root canal treatment with a partial obturation, meaning don't go inside the root canal system, because here we have open apices, and we want these tooth to develop more. So in this case, our strategy will be obturation, but this obturation is different. In this case, what I did is a pulpotomy. As you can see here, we have a nice control of bleeding, so not too much bleeding, but we have blood just at the orifice. And I am placing an obturation material, which is in this case, the bioceramic putty from the bioceramic putty material. So placing it very simply with a spatula, and then we take a plugger, as you can see it on this video, and we compact this material very slowly. The compaction of material like this one is different than the compaction of gutta percha, and is different the compaction of composite or amalgam. So we have to be very gentle. Place it everywhere. Make sure that we don't leave any voids here when we are doing our obturation of the coronal part. So we preserve the pulp in the inside the roots to have an apexogenesis, a formation of the roots in the later on, because this kid was very young, 8 years old. And here you can see how it was sealed with the putty, and after this I placed a glass ionomer, and in the same session, of course, a composite. It is very important if we do such kind of treatment to have a very good isolation from the beginning till the end. And it is, of course, very important to have a good isolation in all the cases when we do root canal treatment, from A to Z, from the access cavity till the obturation of the filling material. So this is the preliminary X-ray. And here you can see we have the putty material, few millimeters, we have sunglass ionomer, and the composite was placed. This is a new case. I did it 2 weeks ago. This is why we don't have a follow-up to see if the roots are developing. But we have to do very good follow-ups in cases like this one. Now let's talk about cases where we need to go inside the root canal system, because this is the real topic. And traditionally, for these cases, we were using what we call condensation techniques. Condensation techniques means the lateral technique, for example, or the Max Padden technique, or the vertical technique, and so on. I will share with you what I do. So I'm not going to go through all the techniques. I will share with you with the techniques that I'm familiar with. And to do these techniques, I based my knowledge and my experience on people that worked before me and long time before me. This is a book from Schilder. And this book, not from Schilder, this is the passable pulp. And inside this passable pulp, Schilder wrote a chapter, canal debridement and disinfection. And at the end of this passable pulp from the 1980s, so very long time ago, he wrote a future of endodontics. And in this part, in the future part, because Schilder was a visionary guy, he wrote that the future will be about obturation. And we are seeing nowadays, in 2022, how much we have revolutions in obturation, bioceramic obturation, MTA obturation, and so on. So obturation is very, very important. And even before that, in 1967, Schilder wrote another article. You probably know it, but I like to cite it every time because we based our techniques on this article, which was the root canal treatment in 3 dimensions. And it was one of the first person who was talking about 3 dimensions in the root canal treatments. At that time, there were no CBCT, there were no scanners, there were only teeth without microscope, without anything, but the concept was already here. And this is a case that I did using the warm vertical technique of Schilder, the classic warm vertical technique that I will show you later on in this lecture, because it is a technique that I am still using in many of my cases. And you can see in a case like this one, that we have a system. And you can see that by applying the technique of Schilder, described by Schilder, we didn't create anything. I am applying just the technique of Schilder. It is possible to fill canals and to fill also accessory canals, anastomosis between the canals, and so on. This is another case. Upper molar, upper 7, MB1, MB2 joining MB1, and from MB2 we have also 2 anastomosis. And this is all done thanks to the obturation technique, because it was not possible for me to go inside these anastomosis. I saw them at the end when even if I am working on a microscope, it's not possible for me to see them. Sometimes we can scout them, but in this case, I didn't see them. And so I saw them at the end of the treatment, and I was like, wow, I have this. And I didn't go in, just by my obturation and my technique. So let's talk a little bit about the rational endodontic treatment. What is the rationale of treatment? The rationale, of course, is to eliminate biologically all the microorganisms, to remove all the organic tissues if we are dealing with a vital tooth. And how can we do this? By cleaning the canals, and to clean the canals, we need to shape them. And finally, we want to have something on the long term, and to have something on the long term, we need to fill the system. To fill the system, to seal it completely, like you seal a composite, like you seal a crown. I always like to say that dentistry is about closing spaces. And also endodontics, it's about closing a space. We have to seal a space very well to make sure that this space that we cleaned will stay on the long term. And this, we know it for a long time. But you can see these 2 pictures. You have a girl working on a big computer in the late 50s. And now we are using laptops. And later we will use more technology, better technology than this. But the concept was still here. It's the same concept, technology change, And the technology is helping us and helping many of us to apply this concept very easily in most of our cases. So the objective of the obturation is to fill the canal, not only the technique of Schilder and or the vertical technique or the continuous wave technique. The idea, and this is written here, the idea is not only to fill the canal vertically, but also to fill it laterally. It is called vertical compaction, but actually it is a vertical and lateral compaction because it is the best technique to fill lateral canals. Now we have the Beausoleil technique, we will talk about it, but this is one of the best techniques to fill lateral canals and to make sure that we will not have problems at this stage. And we know from studies like this one, for example, that we can have a very high success when we are doing a vertical compaction because we have lots of density of the obturation, and better success than techniques with lateral compaction when we have lots of sealer and not very good bond between the cones that we are using. So this is why most of the endodontists are using techniques like the vertical compaction or the continuous wave. This is some micro CTs that we did. I personally did in France in the laboratory to see how is the obturation. And you can see in the coronal part the density of the obturation after the continuous wave technique. And this is in the middle part, and this is the 3D reconstruction of this obturation. And this is the apical part, a very dense, very well sealed system, because the technique gives us possibility to have a hydraulic pressure, and we will see it later on in this presentation. This is also in mesial roots, micro CTs done. This is also a reconstruction. You can see it on the video. You can see a small anastomosis between these two canals, and also coronal, middle, and apical part, very well sealed. And this is another cut. You can see on the micro CT also how it is well sealed in the apical part. And this is the most important part, of course, of our treatment. So back to Schilder, when he said that it's not only vertically, it is also laterally. It is not only about lateral canals. And we know it more now because we are doing micro CTs. On micro CTs, we can see that we have on most of our cases where we have two canals in the same root, we have isthmuses. Here, images of isthmuses of micro CTs. Very nice images of isthmuses. And you can see how these isthmuses can be really, two canals can be open one into the other. And in this part, it is not possible for us to go with the instruments. With the instruments that we have, all the instruments, we need to do a good cleaning, and also we need to have a good arterial pressure obturation. This is a kind of, for example, a band-shaped isthmus from this article from Kellis and al. Very nice images showing this band-shaped isthmus. If we don't close well this part, if we don't clean it well, we will have lots of microorganisms. And guess why we have most of our failures in the mesial root of lower mandibular, of lower molars, and also in the mesial root of upper molars? Because of this. Sometimes we clean, we fill the two canals, and still after 2 or 3 years, we have a failure because probably our cleaning technique and our obturation technique was not good. This is a micro CT also done by our team, and you can see here the isthmus. You can see the two canals. You can see lateral canal here, and also a lateral canal here, and the isthmus, how it was filled, part of it with the gutta percha when working. This is an image also done by my friend, Dr. Marc Habib, on upper premolar. Look, the anastomose between the two canals. So this is a reconstruction of this upper premolar. And look at the accessory canals in this, in the apical part of the root also. And what I showed you till now, it's what is macroscopic. But look at the microscopy. Look at the SEM images. We cut teeth. We saw on these teeth that we have these tubules. And you can have these many images on this. These are new images that we did in Strasbourg. And we can see these microtubules. And when we see this, we see that we are working in another dimension. The third dimension, probably also the fourth dimension. Because it's not only about lateral canals, it's also about cleaning this by using UDTA and filling this, having a good seal of these parts. And to do this, we need to do activation. This is an activation tool from COXO, for example, that can be used when we are using sodium hypochlorite or EDTA. And this is an image even deeper. So microtubules, and inside these tubules, we have other tubules. It's a big word. And endodontics is very small. We need microscope to see that. But if you go inside the details, you can see that it is really a big word. So activation is very important. Look here, how this activation will activate the sodium hypochlorite. By doing this, we will have an acoustic streaming. So here we are working with an ultrasonic activation with more than 35,000 hertz, I think, and as close as possible from the apical part. And by doing this, it will be possible to us to use it with sodium hypochlorite, EDTA, remove mid layer, clean all the lateral canals as much as we can, and at the end have results like this one, with 2 lateral canals, for example, filled in this upper premolar with a 2-1 configuration at the end of the treatment. So as I told you, we have lateral canals in the apical part. We can have anastomosis in the middle part. All should be closed. If we look at the Hess images from the 1920s, we can see that the anatomy is even more difficult than what we are closing by using the best techniques that we have. But we should do everything to have a good hydraulic pressure without endangering the tooth, with safety of the tooth, to close all these parts. Like this one here. Or here, middle root, apical part, many portal of exits. Portal of exit here, a portal of exit on this premolar on the other side. This is a very nice article by a Chinese group that showed that very nice images, also micro CTs, because by using micro CTs, we can see not only lateral canals, but we can see lateral canals coming from other lateral canals, so even smaller than these lateral canals. And these images are amazing. They are like paintings. This is why I like so much this topic of the obturation. So, you know, this kind of obturation will give us the possibility to clean parts that we were not able to shape well. Here, for example, you can see that it was possible for me to go with this small file inside this exit, but it was not possible to shape it, at least under my hands. So what I did a very good cleaning, I shaped the other canals, and I did a very good hydraulic pressure. And here you can see after many years of follow-up how it is still filled with our obturation technique. It can be sealer, or it can be gutta-percha. In most of the cases, it is gutta-percha. So what we can say is obturation should go there in places where it was inaccessible for us, in places where the anatomy is difficult. Like here, for example, also a lateral canal from the middle, or a true canal, a real canal, a long canal, but very inaccessible, very difficult to access. Maybe with better clinicians, it's possible. But in under most of our hands, it's not possible to go in. So it was possible to fill this canal also here, as you can see, with all the other 4 canals. And it's possible nowadays to do a conservative shaping, not necessarily the old, large, very nice tapered shaping of Schilder, very conservative to preserve the tooth and at the same time to have hydraulic pressure with this lateral canal here in the middle of the root of the mandibular molar. Or here in the same, on this premolar, for example. In this premolar, I knew when I started the treatment that there was something here. But I went in this canal only with a number 10. It was not possible for me to go with bigger files. I counted on the obturation. Of course, this is a missed canal, but by doing a good obturation and good cleaning, it was possible to fill these anastomosis. And this is what I call why I call vertical compassion as a safer. This is a very old article from the group of Schilder, showing something very important, and I want you to listen very well to this, talking about adaptation. Adaptation is essential. Adaptation is very important. Adaptation of the GP on the wall when we are working about vertical compaction. So in cases like this of vertical compaction, we need to have a very thin layer of sealer, very thin, and lot of gutta-percha. So we can say that in this kind of obturation, the king of the obturation is the gutta-percha, which will not be true with the bioceramic obturation. We'll see it later during this presentation. So we have very thin layer, around 40 to 100 microns of sealer. So mainly we have gutta-percha. And many articles showed that all the techniques are comparable, but we can see some articles showing that the technique of the vertical compaction will give you more density than the old lateral compaction or the old single cone technique, not the new technique with the bioceramic techniques. So let's talk a little bit about the technology that we will use to do this obturation. Simple technology, actually. We started by using this kind of material. Not me, before me, older endodontists, they started to do this. And then we had devices like the touch and heat and the System B. And these all devices, they work on heat. And all the vertical compaction actually work on heat. The idea is to work on heat. And we know that we need to go very deep inside the root canal system, because we know that with all these devices, we will have the heating of the material of the GP 2 or 3 millimeters down where the heat goes. So if we are at 5 millimeters from the apical part, the last 1 or 2 millimeters will not be heated. Will not be heated because the heat conduction will not go there. And this was asserted by this article from Goodman and Schilder. Very nice article about the thermal properties of gutta-percha. And now we have devices like this one. This is the COXO device that works exactly the same. And all these devices, even when you are using at 200 degrees for continuous wave compaction, the root surface temperature assessed by this article showed that we will not have an increase of this temperature more than 10 degrees. So we will not have any harm of the ligaments. And this is why this technique is used every day. And it is an evidence-based without any problem of heating of the ligaments around the roots. We also need hand materials. These are the Schilder pluggers. There used to be so many. Mash 2, the great professor who was one of the students, was one of the disciples of Schilder, created these pluggers that I am still using till now, number 4, 3, 2, and 1, because it's more ergonomic, so we have less pluggers. And we need, of course, the plugger to be very well fit inside the root canal system without endangering the tooth. So it should not fit on the walls. We need to have the biggest plugger that will not touch the walls when we are choosing our vertical compaction. So in these images, you can see a coronal plugger, how it is far from the walls, but large enough to give the hydraulic pressure. A middle plugger, if we are doing a vertical compaction, classic vertical compaction, and an apical plugger, always we should not touch the walls when we are working with it. And also we need to have GPs. So this is our material: sealer, GPs, pluggers, and a device to heat. The first very important thing is to do our tack back when we are doing our technique. Why the tack back is important? Remember what I told you before. When you are doing vertical compaction, you reach 5 to 4 millimeters from the apical foramen. So the apical 1 millimeter is not heated, and we don't want it actually to be heated. We want this part to be hard, because if we heat it, it will go out. So this part, we will have a good, we should have a good adhesion, a good fit of the gutta-percha and this part, first of all. And also the tack back will give me the resistance form. So the tack back is representing actually the apical plug. And we will see later what is the coronal plug. We need to have sealers. So sealers, they can be zinc oxide type sealers, like this one, for example, the Essence seal, for example, or the pulp canal sealer from Care, for example. These sealers are very good. I'm still using them sometimes. And you can see how these how should be malaxed, how they should be mixed, and to have this kind of consistency when we are doing a vertical compaction. So now let's see the technique of the vertical compaction. We have to adjust the pluggers. As I told you, we are adjusting the plugger to make sure that the pluggers are well fitted. We can see it on this block. Many pluggers if we are doing the simple vertical compaction, and I will show you with the continuous wave that we don't need so many pluggers. But I think that especially if students are looking to us, we have to start to look at the one vertical compaction before doing the continuous. We have to learn how to do it. This is how we do the confit, tack back. And after this, we will place, of course, we will check the lens. So 50 millimeters, till the foramen, we will cut a little bit, half millimeter. We can place some sealer inside the root canal system, and we'll place our cone with sealer, and then we can start our vertical compaction. Now I'm going to show you on this other video how what is the principle of the technique. The principle of the technique is to create a coronal plug, as you can see here. And this is done without sealer because I wanted to show you how the adhesion of the gutta percha is very well in this kind of vertical technique. So a coronal plug, apical plug is the tack back, and we will go progressively with this plug from the coronal part till the apical part. So this plug is going deep and deep inside the root canal. So I am heatening, compressing, hydraulic pressure. Here I still have voids because I am far from the 4 millimeters. So I will compact more, as you can see here, compacting more, heating, removing a little bit of GP, and again doing heating. I'm showing you this just to understand the concept of the technique and see how now we don't have any more voids. So if we used sealer in this case, the sealer would have been very, very, very thin because we created a plug and we went from the coronal part to the apical part with this plug. Here you can see that we will not have at all any more voids. We have a big part of GP closing the system, and the sealer is here just to seal the gutta percha to the walls. Clinically, this is how it works. So on this upper molar, it is very nice to do the compaction obturation technique under the microscopy. You can see how I'm doing it with the microscope, removing a very little part, and then I can see where is the GP, and I can do my compression directly on this. So I will not work on the walls. If I work on the walls, if I press on the walls, what will happen is that I will create too much stress on the walls of the tooth, and by doing this, I can have a crack later on these tooth. So this was done with the MB1, and also you can see it on the MB2. So I am heatening, removing, this is the classic warm vertical technique, removing a small part of GP, and then compacting, creating a plug coronally. My apical plug is the tack back, and I need to decrease the distance between this coronal plug and this apical plug to be able to close these canals and these lateral canals and all the anastomosis of the tooth. This is the technique of the continuous wave. And this technique that you can use with the devices like the COXO one, you can go directly from the coronal part to the apical part, because in this technique, the heater is also a plugger. So we go 6 millimeters from the apical part, and then we press with the heat. We wait there for 5 to 10 seconds, and after we heat again, remove it, and use the apical plug. So in a treatment like this one, we will use only a coronal plugger, the big one, and the apical plugger. I did it on this lower lateral canal, lateral tooth with 2 canals, joining canals. You can see how it is important to do the compression at the end to make sure that we will not have any retraction of the GP. And you can see the treatment. This is the down pack. A good down pack, how do you know it? How do we assess the good down pack when we are working with students? We ask them to take an X-ray of the down pack. And if we don't have GP on the walls, we can say that this is the best down pack we can have. Because in this way, it was possible to go with the best plugger, best fitted plugger, till the 5 millimeter, apical 5 millimeters. And here you can see that the 2 canals were filled, type 2 of Vertucci, And after a few months, we have the beginning of the healing on these particular tooth. The same technique on the smaller mandibular molar with also a special anatomy. We have placing the cones with a little bit of sealer, of course, after we assess the tack back and the lens, placing in all the canals. And after this, I'm cutting the cones to create the coronal plug. So this is the coronal plug. And now I can do directly my continuous wave technique. I go from the orifice till 6 millimeters with heating. And after reaching this 6 millimeters, I remove my finger from the heater, and it will go alone till the 5 or 4 millimeters on the apical part. Because if I heat till the end, maybe I can have overfilling. Maybe I can have softening of too much gutta percha in the apical part. So I'm doing this using the plugger at the end to make sure that there will not have any retraction. Also in the distal canal. It is done also in the distal canal. Wait a little bit, 5 to 10 seconds. We can count 1001, 1002, 1003, etc. And plugger. So all 3 canals were filled. And here you can see the cone fit, 0.5 millimeter from the foramen, and then the obturation with small puffs. These small puffs, they are not endangering at all the periapical region. And in most of our cases, we have these kind of puffs, as you know, if you are doing the vertical technique. Of course, we don't want to have too much sealer going out. And this kind of technique can be used in any kind of anatomy. Difficult anatomy like this premolar with many portal of exit, many deep split with deep portal of exits. Here you can see on this video, how it is possible to do the down pack. We are doing it with small pluggers, going inside. I am doing a kind of technique between the vertical and the continuous wave technique. We have a large part, coronal part here with a large canal, and then we have a split in the apical part. And now I am using this kind of device, to do the backfilling. Because when you do a vertical or continuous wave technique, always you will have to do the backfill using these kind of devices of injecting gutta percha. And you will see how the gutta percha will come inside the canal like a cream. And you will have a result like this one. As you can see here, we have 3 canals, a deep split, lower premolars, very difficult cases sometimes and very easy in other cases. And you can see how the seal was done with this particular treatment. So after talking about the continuous wave technique and the vertical compaction technique, which are very similar techniques, with one of them is an evolution of the other one with easier handling, especially for general dentists, and of course quicker than the other one. Now let's talk about the single cone and the bioceramic technique. In the cases of single cone and bioceramic technique, we are using a single cone technique, but we are not using a single cone technique with a normal sealer that we usually use, which is the zinc oxide sealer or the epoxy sealer. We are using a bioceramic sealer, which is very flowable, as you can see. We will see it in the cases that I will show. This is a single cone technique using the bioceramic. Bioceramic sealers are like MTA, tricalcium silicate sealers. So they are very biocompatible, and they are, if you have lesions, we have fast healing with this kind of sealers. So first thing is to place the sealer, like you can see it here, and see how it is flowable, how it goes inside the ramification when I am placing it. Without too much pressure, you should place it, because if you place it with too much pressure, what will happen is that we'll have the sealer coming outside, too much sealer coming outside the canal. So after doing this, you can place the GP points that you choose in one of the canals, And also here you can place it in the other canal. By doing this, you will create also a pressure, and you will have a little bit of puff, but this puff should not be too much. When I started using this technique, I had cases with too much sealer going out. Because why? We were using injection technique inside the canal with pressure. You want to place actually the injection needle like here. On this case, you place it in the middle of the canal, not in the apical part. And after that, you can use a carrier to bring it in the apical part. Here I am using the reflex carrier to bring it down to the apical part. And then I will place my GP point in one of the canals, small compression, doing the same on the other canals. You see, without pressure, not using any pressure. And again, I am using the same carrier, which is a reflex tip that I am using. I go with this tip, 1 millimeter till foramen. By doing this, you will see that the sealer will go deep inside the root canal system. Then I am cutting the cones, doing, of course, my compaction in the coronal part, and you can see how nice obturations we can have with this kind of technique of bioceramic and single cone. You can have it, especially if you are working on curved canals. Why? Because in cases of curved canals, what is the problem? The problem is that if you are using a plugger in the apical part, even if you are using a night-eye plugger, it will never go inside this curvature. So this is a case, for example, of a retreatment. In this case of a retreatment, we have a canal that is filled short. And at this part, what do we have usually when the canal is filled short? We have usually a ledge. So we need to bypass this ledge, first of all. And then after bypassing this ledge, we have to go inside the curve. We have to preserve the curve. Very important to preserve the curve. Here the case was done by using the XP Endo shaper to remove the GP material, which is a very good instrument to remove the GP material. So this is the retreatment phase. This instrument is used just to remove the GP. And after this, we will use hand file, and the hand file. With the hand file, we will go to the apical part, make sure that we have the patency, and after this, we can start doing our shaping like it is done here. So shaping is done with glide path files. I am showing you a case of shaping because a good obturation cannot be done without a good shaping. This shaping can be a conservative shaping, and this is what we do when you are doing bioceramic techniques. In most of the cases, we can use just 04 tapers. In vertical techniques, it's better to have 06 tapers, but even with the 04 taper, we need to have a special shape. If we don't have this special shape, it will be very difficult for the sealer to go inside the canal easily, even if it's a very flowable sealer. After shaping, here you can see how I am injecting. So I don't go till the binding point with the with the injecting material. I am just placing the middle of the root, the injecting, and then I'm going to place the GP points with some sealer, cut the GP points, very easy technique, only 30/04 with the taper. On this case, I use the R motion reciprocation files, and I am doing my compaction in the coronal part very nicely, as you can see. And after this, we will clean very well the axis cavity as it is here, and then we can do our build-up at the same session because we didn't use any zinc oxide. And here you can see how the case was done. So first of all, patency files. I like to take x-rays with patency files when I have difficult curved canals. And then you can see the curvature and how it was possible to go with the sealer inside the curvature. How do I know that it was possible? I know it from the puff. This proves that it was possible to go, but not too much puff, because if I have too much, I can endanger. If I have the nerve or the sinus, I don't want to go with all this sealer in this apical part, even though it is a sealer that is, of course, biocompatible, because it is like bioceramic is like MTA. And here you can see a distal shift showing the joining point of these two canals after the obturation, and the buildup, just the buildup, was done at the same session. After this, the case was referred to the referring dentist who did a crown on this particular tooth. Another difficult anatomy here, this molar, as you can see it here, conservative shaping, very long molar, so very difficult to do a condensation technique, because very difficult to go inside curvature with this condensation technique. And here you can see that we had joining canals, and when we are doing bioceramic technique with joining canals, most of the cases we have the sealer that goes in one of the canals and come out from the other canal, as you can see it here. So we do it in these canals, and then we can use a carrier to go in there to just make sure that the sealer is going there. And I learned this technique from my friend, Dr. Riccardo Tonini from the Sta Italiano group. Here I am using just 2504 cones inside these mesial canals, and I will do the same, exactly the same, inside the for the distal canal. And you can see also orthogonal X-ray and the distal shift, a nice anatomy, curved anatomy. I don't want to enlarge it too much because I want to preserve, of course, this anatomy while doing my shaping, and it was possible to do it here. This is another case, interesting, because in this case, I have two kinds of obturation. First of all, the case was sent to me like this, so very calcified canal, and the dentist who worked on it couldn't find the canal, so went a little bit on the buccal side, and we had a small perforation on this buccal side. So we find the canal, the true canal here, and after doing this, I closed the perforation by using MTA, simple MTA here. You can see how I am closing it. And here I am doing my tack back with the cone inside the true canal, placing bioceramic. So I go till the binding point of the needle, remove a little bit, inject slowly, remove, put a little bit of bioceramic on the cone, go there, cut it, and it's done. And we have this kind of result with a little bit of sealer coming out. So in this case, we had obturation of a perforation with a bioceramic, MTA. We could have used also putty in this case. After doing this, you can see the pink is the gutta percha in the middle, and here we have the perforation that was sealed. This is the case. So calcified, we found the canal, it's a very small file, and then enlarged conservatively this canal because the canal to begin with was very small, so we didn't want to enlarge it too much. And now we have other material that are coming out, and this is one of the material that my friend, the Professor Aysam Khalil from St. Joseph University developed, and he had a great idea to combine with this K sealer, a powder containing zinc oxide with all the properties of zinc oxide that we know, and calcium silicate, which is the bioceramic material. So combining these two, we can use both of them, and we can use the technique of the vertical compaction by using this kind of sealer. So the liquid can be, it's eugenol, canal embalsamment, mineral oils, and excipients. So this is a very good idea, and I did, so this is the bioceramic mixed with the 𝐄𝐧𝐠𝐸. We have all the properties of calcium silicate and zinc oxide. I did some cases with it. Here you can see how I am mixing it. Very quickly, we can mix it. The mixture is a little bit different from the mixture that we have with simple zinc oxide eugenol mixers because we have this bioceramic. So it is a bioceramic and zinc oxide that we mix. It is not injecting. We can use it as a single cone technique, or we can use it in a compaction technique. And here I used it in this upper molar in a compaction technique. Here you can see two canals that are joining. When I am removing the material from one of them, from the other canal, it's drying the other MB2 canal, and you can see how the material is coming out. See how it's flowable coming out from the other canal, placing the two cones, and after this, in this case, I used the normal warm vertical technique in both MB1 and MB2. I like this technique because I have a very good control with it. I can see very well what is happening inside the canal when I am doing my condensation. Of course, if we are using magnification like microscopy, here I'm using magnification at 10. Sometimes I go even at 16 to see better inside the canal when I'm doing my compaction. And this is the case. You can see how it's possible in long canals to have a good obturation with very small puffs like we want them usually. And finally, all these techniques, they cannot be used in some cases. And in these cases, we need to do the MTA plug technique. Before this, and these cases were done when I was a student. When I was a student, the MTA was not so popular. It was existent, but the plug, we didn't have the good devices for the MTA plug. So we were still doing vertical compaction. And I did cases with very large foramen with this vertical compaction. Here you can see it. But what is the problem with these cases? The problem is that I need to enlarge too much, because to do vertical compaction, we need to have a taper. If you don't have a taper, you will not have a direct pressure, and you will not have the resistance form. And what will happen is the material will go out. So we need to enlarge too much. And by doing this, look how the canal is large in the coronal part. So we are not using this kind of obturation anymore in cases where you have very, very large canals. Because we know that to use condensation techniques, we need to have taper, so we need to have the objectives of Schilder. And you know that Schilder wrote the article about the shaping after the article about the filling, because he wanted to create a shape that suits to the theory of his filling. So he needed to have this preparation, tapered preparation, small apical opening, and so on. So if we naturally don't have this small apical opening, we cannot use this kind of obturation. And it is also not also good to use the bioceramic technique obturation, because we can have too much overfilling. So we do what we call the apical plug. Apical plug is to do a small plug of MTA for 5 millimeters in the apical part. And this was described by Tora Binjad, of course, and many other authors. Here you can see, for example, a V-shaped canal. It's an old patient, so I couldn't do any apexogenesis, of course. In this case, I had to find a solution. To find a solution is to place an apical plug. MTA here, and then we placed a GP. So how we do it? We place the material, the MTA material, using a device like this one. This was a MAP1 device, injecting the MTA, and then my technique, but there are other techniques, is to use just paper points. With the paper points, I go there and I do small compactions. If the foramen is very, very large, we can use a membrane, a collagen membrane or a sponge. I prefer membranes. And to have a good control in the apical part. And at the end, you can see how it is clean in the coronal part and how we have a good apical plug. After this, we can do our injection technique. We make sure that we have a good plug, and then we can inject the material using the injecting device. You can use the injecting device of COXO. It is all based on a pressure that you inject the material. The gutta percha is flowed inside the canal. It's very nice for the backpack. It is difficult when you are using it as an obturation technique, even though some of my colleagues, like my friend Dr. Calogero from Sa Italiano, also Endontics, use it to inject, to fill the canals entirely from the coronal part till the apical part. But in this case, it was used only. Here you can see the apical plug. What is important with the apical plug is always to take an X-ray just before you take an X-ray just at the first plug. When you place the first plug, you take an X-ray to make sure that the plug is just at the foramen, because I won't want it short. If it's short, then I can push a little bit then I can use a plugger. And if it doesn't go in, I can remove the material because the material is still soft. After doing this, I have the apical plug, but I will not fill the coronal part directly. I will wait for this apical part to set for 24 hours, make sure with a file that it is hard, and after making sure with a file that is hard, then I can do my injection and place my gutta percha. And finally, because we are humans and because I don't have always success, I can have many failures. We try by our techniques to have as less failures as possible, but still we have failures, and this is why we are progressing. We learn from our failures. Failures comes mainly in endodontics from the anatomy. Look at this anatomy, for example. You can see on this anatomy we have indents invaginatus on this canine. The treatment was actually very difficult. We took a CBCT, and you can see this dents invaginatus. The incidence to have it on canine is very low. We have it more on lateral incisors, but it is possible. And the incidence of having an invagination of type 3 is also low. Here we have invagination of type 3, meaning we have 2 portal of exit at the end of the root. So we had to do this treatment because this child was suffering from apical periodontitis. So the first thing was to prepare the access cavity, as it is done here. We are assessing the orifices. I am making sure that I can see very well what is the anatomy. And then I will go in to make sure to shape these canals, difficult canals to shape, because we don't have the normal form of the canal, the usual form of the canal. Here you can see the 2 exits, and of course we have lots of anastomosis in cases like this one, in the middle part. So I'm doing my glide pass using an instrument called the Easy Pass, one of the very, very good glide pass instruments. Going inside there, making sure that I can reach the apical foramen. This is my shaping technique. And then here I'm doing my shaping in the canals. Also, of course, these instruments, the shaping instruments, will go inside, but it will go only on the tunnel, and it will not go inside these anastomosis in the middle of the canal. This is why these treatments are very difficult. They succeed in some times, but in other cases, we will have, and this is the access cavity, of course, at the end. In some other cases, we can have a failure, and this was the case here. Here you can see we filled the canals. The filling is not, I was not really satisfied with the filling. We asked the patient to follow up after a few weeks. He had a fistula on these tooth. The fistula disappeared and came back. So we decided to do a surgery. The surgery was done by my friend, Dr. Sharb al-Allam. Here you can see how the orifices were very large orifice. So he's placing MTA after preparing the surgery. And here you can see how it was possible and how much big was this anastomosis comparing that was the obturation that we did. Even by using bioceramic sealer, it was not possible to go inside these anastomosis, and this is why we had a failure in this case. So obturation can be also a surgical obturation, and when we do an apical surgery in endodontics, we have to do obturation. So obturation is also about surgery. If we cut just there, remove the cyst, then after a few months, we will have again the lesion, apical periodontitis, because we didn't remove the cause of the failure in this case. So I finished my presentation. To finish, I want to say that the obturation is one of the most important part of the treatment. Why? Because our treatment is a 3-course menu. We have the cleaning, the shaping, and at the end, we have the dessert. And we all know that this dessert, for many of us, is the best part of a meal. So this is why I like a lot white lines, despite what some people say. I hear some people saying white lines are nothing. White lines when they are well done, and if all the treatment is well, then we are sure that the person who worked is a meticulous person, and we can see it by a result on the X-ray. And this is why it's important. Of course, if we just shape and put cones without cleaning well, without doing activation, without using many techniques to clean, of course we can have failures. But if we don't do a good obturation with a very good cleaning, we will also have a failure. Thank you very much.
Yeah, many thanks for Dr. Marc to share your excellent course. I saw there are many questions about our course.
Thank you.
Thanks for your lecture. So let's see some question. There are many questions.
Oh, very long questions.
Yeah.
This is a book. It's not a question. So you will read the question because I don't see it very well on the screen.
Yeah, let me see. Thank you, doctor. One of my colleagues, when I show him my observation case with conservative enlargement to, for example, 25, 25-fold or 30-fold, tell me that he can't be convinced about the conversation preparation of the canals. He said that when we prepare till 25-fold or 30-fold, we can eliminate all the bacterial inside canals, even if we do a good irrigation and greening protocol. And another thing that when we want to do a fiber post or post and core, we face a difficulty with preparing this space. What do you
Yeah,
think? Yeah.
it's actually, I want to thank you for this question because it is a very controversial topic, actually. And I agree with you in a part, and I disagree in other parts. You know, most of the cases that I showed you are cases where I did a taper of more than from 0.6 to 8.08%. But in some cases, if you have a small canal, if you have a curved canal, it is very difficult to shape with a very large taper, very large taper. This is why I'm not using 3004. I didn't say that I'm using 3004 in all my cases. In some cases, I may use 3004 when the canal is very thin, like this central that I showed. We can go very deep with our needles. If we are using, for example, a needle like the E-reflex needle, we can go with this kind of taper 2 millimeters from the apical foramen. With the activation material, we can go also very, very deep, believe me, if you are using, for example, also sonic activation. And of course, you cannot do vertical compaction in cases like this one. You need a flowable material that will go very deep. So the concept is the concept of conservative dentistry. And this concept is based on the cleaning. Shape, we still need a shape, but we need a shape with a cleaning. And this cleaning can be done with activation. You can use laser. You can use whatever you want to make sure that you are cleaning as much as you can, because you know your tip is going deep. You know your activation material is going deep. You know that your technique of obturation, hydraulic pressure, bioceramic is going deep because of the flowability. In these cases, you can use a 3004. To tell you the truth, I use 80% of my cases, I go with the 0.6 taper, and nowadays in my clinic, and in 20% special cases, because I believe, and I strongly believe, that we have to adapt our technique to each anatomy. I showed at the end a slide with recipes, but endodontics are not recipes. We have to adapt our technique with anatomy. If we have a curved canal with a 90-degree curvature, it is not possible. Believe me, it is not possible to go with an 0.6 taper in such canal. So we need to find a solution, and the solution is to use a 0.4 taper. 0.4 taper with a 30 tip. 30 tip, yes, 30 tip. So I never talked about 2504. I never used 2504 tapers. So minimal is a 3004, sometimes 3504 if the canal is larger. And in most of the cases, vertical compaction, I use 0.6 taper, and sometimes even 0.8 taper.
Okay. Thanks. And for the next question, what is your view on complete MTA obturation being for popular?
Well, we have a great endodontist called Terrucci, He is very well known for his techniques of removing files, and he is very well known also by the technique of the obturation. He used only MTA for the obturation. Actually, it's a very good technique, of course, but it is a difficult technique to apply in thin canals. And knowing that the material that we are using in vertical compaction and even with bioceramic technique condensation are techniques that works very well, we don't need, in my personal opinion, we don't need in all the cases to use MTA. But some people will do it. It's not wrong to do it. It's difficult. And if we want to place a post, of course, you cannot do it to the orifice. And this is my answer. So it's possible to do. It's difficult. It's more difficult. When it's large canals, more than 50 foramen, I always do MTA plug. But less than this, I am using or vertical condensation, continuous wave, or bioceramic condensation. And concerning the question about fiber post, of course, if you have a fiber post, you have to adapt yourself. You know, when you are doing your root canal treatment, if you know that you will do a fiber post, then you will enlarge the coronal part more than an O4, of course. And O4 doesn't mean necessarily that you need to do O4 all the long canal. You can do orifice opener in the coronal part and O4 just in the apical part.
Okay, for the next question is how to activate sodium hypochlorite in severe curved canal and in open pad with ultrasonic activator.
You can't. You need to use sonic activation. Sonic activation with flexible tip. Also, again, we have to adapt. So you need to have an ultrasonic device for activation. You need to have a sonic device also for activation. Because with sonic device, you will have a plastic tip, and with this plastic tip, you can go 2 millimeters from the apical foramen and do your activation.
Okay. For the next one, how much of sear extrusion beyond the pad is acceptable?
You know, the best, but my answer is not really based on a scientific basis because I cannot give you a number. But clinically, the best puff, so the best extrusion is to have like a dot at the end of the foramen. When you have this, this is the best extrusion that you can have. Do we have this in all the cases? No. Probably I showed you some of my cases where we have more material outside. Is this endangering the root canal system? If you have sealer extrusion inside the mental nerve when you are doing a lower premolar, number 5, then of course it's forbidden to place sealer there because you are harming the patient or the mandibular nerve. So it all will depend on what you are working. For example, if you are working on the lower 7, sometimes very close to the nerve. In cases like this one, I will adapt also my technique of obturations. I'm going to be a little bit controversial. I can be a little bit short also because I am afraid to place sealer inside the nerve because I don't want to harm the patient.
Okay. And for the next one, if we do not have talkback, is that right to use bioceramic sealer?
This is a question that I like because this is a very clinical question, and this is something I ask myself actually. Tackback is very important in the vertical compaction technique because tackback in the vertical compaction technique is also what I said in the lecture is also the apical plug. So in bioceramic techniques, we don't really need this apical plug. But probably if we don't have a tackback when you are using the bioceramic technique, we can project more sealer in the apical part. But I am saying this just by empirically. Okay, so it's better always to have tackback. And remember also that at the end of your obturation, even if it's single cone obturation, when you need to cut the cone and to compact a little bit the GP. By doing this, if you don't have a tuck back, you can have also over extrusion of the aperture from the coronal part in the apical part. So it's important to have tuck back. Not as much important as vertical compaction techniques, but it is important to have it.
Okay. And there are many questions here. So we need your help to comment under the question after the course.
Yes, I will do it. I will
Yes.
do it.
And you choose the best question and tell Marvin, then we will post on our Facebook. Yes, many
Great.
thanks for your lecture. There are many questions still not replied. So after the course, we still not need your help to reply them.
So I will choose the best question when, in 1 hour, or because if are still asking questions, I have to wait a little bit, right?
You
Or
can choose the best question after the course and
okay,
tell
okay,
Marvin he will post on our Facebook.
okay, great, great,
Yeah,
okay, great, great.
thanks for your help.
Thank you so much, Judy, and thank you so much, Marvin and Bruce, who contacted me for this webinar. I was very happy to give this webinar today, and maybe
Yeah,
to others, other occasions also. Okay, thank you very much,
thank you
and
very much.
see you soon.
Yes, you. Bye.
Bye.